Extremely sorry for that technical glitch, everyone. I hope I am audible now. Thank you
Yes,
so
ma'am.
much. Thank you so much. So this is Sripriya welcoming you again for the last and 20th session of Foundation course in Palliative Medicine for this cohort. Today we'll be discussing in detail about methadone, and we have the Additional Director of TIPS, Trivandrum Institute of Palliative Sciences, Dr. Sunil Kumar, joining us for the session. Since he had already addressed this cohort earlier, without much ado, I welcome back Dr. Sunil Kumar for taking this session forward. Sir, over to you.
Thank you, Supriya, and good afternoon, everybody. So we will move on to methadone. Is it visible, Supriya? PowerPoint?
Sir has started screen sharing message has come, but the PPT is not visible yet.
Okay. Supriya, it says your screen sharing is paused. I don't know what is the problem.
Sir, we are seeing only black screen from your end, sir.
Yeah, but I can see in my screen it is the sharing is paused. Okay, resume share. Mm.
So, Lisa, can you try one second? If it doesn't work, maybe we can try some other.
Not coming. I don't know. There is some problem.
Sir, if possible, you can just share across the PPT to.
Yeah, I mentioned on opioid receptor agonist. You know that because of the action on opioid receptors, it can produce analgesia. But because of that itself, it can also produce some of the side effects like respiratory depression, sedation, constipation, nausea, urinary retention, pruritus, edema, which can also occur with other opioids. Okay, next. And we told that methadone has NMDA antagonistic action. And can anybody tell me what is tolerance?
The person will not be able to get relief from the usual dose of the same drug.
Yeah. So the person need to use more drug to get the same relief, isn't it? Suppose a patient has pain who is on 10 milligram of morphine, getting pain relief of 5 by 10. But after some time, maybe after 2 weeks, this person needs 15 milligram to get the same pain relief of 5 by 10. Maybe after some time, it will move on to 20 milligram, 30 milligram to get the same pain relief. So that's what is known as tolerance. So this can occur with opioids also, but it is very rare. But in the mechanism of tolerance, NMDA is the receptor which is supposed to play a pivotal role. So because of NMDA antagonism, methadone has also action to reverse and prevent tolerance. So you can see that here are 4 patients, and you can see these patients are on thousands of milligrams of morphine. Not morphine per se, but this is the morphine equivalent, which is converted from other opioids. Some patient, the patient A is on 12,000 milligram of morphine equivalent, and patient D is on 1,000 milligram or 2,000 milligram of morphine equivalent. And all these patients, next, all these patients was started on 10 milligram methadone 8 hourly, and all of them had very good pain relief. So understand that methadone would be, or methadone can prevent and reverse the tolerance which can occur with other opioids. So all these patients were on thousands of milligrams. One patient on 1,000 milligram and other patient was on 12,000 milligram. But all these patients needed only 10 milligram of methadone 8 hourly. So it is very unusual to start a patient on more than 30 milligram. And usually for pain relief, the maximum dose of methadone requires would be 30 to 40 milligram. So this is because it also acts as a NMDA antagonist. Next one. And all of you know that because NMDA antagonist plays a role in neuropathic pain also, methadone is a good analgesic in complex neuropathic pain. Next. So we also talk that methadone inhibits the reuptake of noradrenaline and serotonin. So that's the mechanism of action of tricyclic antidepressant. All of you know that tricyclic antidepressants are used to treat neuropathic pain. So this is another mechanism by which methadone would be more beneficial in neuropathic pain comparing to other opioids. But at the same time, it can also produce a problem or side effect known as serotonin syndrome. And you can see that many of the SSRIs or medication used to treat depression, when it is used along with methadone, it can precipitate serotonin syndrome. I haven't seen any until now, but theoretically this is possible. Next. And these are the symptoms symptoms and signs of serotonin syndrome. There might be cognitive changes, autonomic instability, and neuromuscular changes. Patient might be agitated. There will be hypothermia, tremors, rigidity, seizures. So just keep it in mind that when you start a patient on methadone, already on SSRIs like escitalopram or something like that, and the patient develop hypothermia, agitation, tremor, think of can it be a serotonin syndrome? Okay, next. So we told that methadone has 3 mechanism of action, and because of that mechanism of action, methadone is good to treat complex neuropathic pain, as well as it will help to prevent and reverse the tolerance. So methadone actually made available in India for as an analgesia, I think for analgesic in 2018, but it was available even before that to treat opioid use disorder, which is used as a opioid substitution therapy. But for pain management, it is recently available in 2018. And when you need a chronic or around the a medication to treat the pain around the clock, it is very helpful because the mechanism of action of methadone, the duration of action of methadone is 8 to 12 hours. So you need not dose like morphine, which is every 4 hours. But methadone need to be given only 8 to 12 hours. And it is very helpful in patients with renal impairment because its metabolism excretion is not through renal route. And it is helpful to treat neuropathic pain. And if the patient develops tolerance, so if you see a patient who is on hundreds of milligrams of morphine equivalent, maybe suppose the patient is on 200 milligram of morphine, that patient may need only small dose of methadone and can get good pain relief. And some patients can develop hyperalgesia, which can be produced by opioids. So opioid-induced hyperalgesia is a very well-known entity, and it can be treated with methadone. And we can see there are some patients develop neurotoxicities of opioids like delirium, myoclonus, extreme drowsiness, etc. In such situation, you can start the patient on methadone. And I have seen some patients with allergy to opioids, and in that case also, methadone would be helpful. Next. So, like morphine, it is also absorbed from the upper small bowel, but compared to morphine, its bioavailability is more. It's about 80%. And will the morphine be absorbed sublingually? Anybody?
No, sir.
No. So morphine is not usually absorbed sublingually, but methadone can be absorbed sublingually. You can see about 30 to 36% is the bioavailability. And rectal administration is also possible, and it is 80% is absorbed. So methadone can be given orally, rectally, sublingually, and this is what is possible with oral preparations. And in India, we have only syrup and tablet. But in foreign countries, they have injection which can be administered subcutaneously and intravenously. We don't have it. So after absorption, it is metabolized in the liver. So next. And after metabolism, it is distributed into the tissues. So you can see next. Please come back. So when you administer methadone, it will be seen in the blood for about 2 to 4 hours. So during that time, you will get pain relief. But immediately after that, it will go into the tissue binding sites. So you will not see any methadone when you administer methadone for the first time. And what happens is after a few days of administration, that means about 5 days or 5 to 7 days of administration, these tissue binding sites will get saturated. Next. So you can see next. Okay, so you can see that tissue binding sites get saturated, and once it is saturated, then when you administer methadone again from this tissue binding sites, some of the methadone will get detached and will liberated into the systemic circulation. So the free fraction in the systemic circulation will be giving pain relief. And you can also see that most of the free fraction of methadone is bound to alpha-1 acid glycoprotein. And there is a small fraction which is available for action or for pain relief. And it is very important to understand that. Can you come back, Supriya? One more. Yeah. The average elimination half-life of methadone is 22 hours. Or when what is the when would the morphine dose stabilized? What time is required to stabilize the blood level with morphine? Anybody? How many days will it take for the morphine to get a stabilized blood level? Anybody? Am I audible, Supriya?
Yes, sir, you are perfectly audible. I believe the participants are.
Okay. So morphine will take 5 half-life to get the blood level stabilized. 5 half-life means what is the half-life of morphine? Anybody?
Anyone has any response? Because we have been hearing about morphine for quite a long time, and we are at the last
4
session
hours.
of this batch.
Yeah, 4 hours. So approximately 5 half-life means 20 hours, isn't it? 5 into 4, 20 hours. So morphine will take only 1 day to get the blood level stabilized. But in case of methadone, you can see the half-life is 22 hours and 5 half-life is required for the blood level to be stabilized. That means methadone will take about 5 to 7 days to get the blood level stabilized. So what do you understand from this statement? Anybody? Methadone will take about 5 to 7 days for the blood level to be stabilized.
So we will have to give other pain. We cannot stop morphine.
Yeah. In other way, you can say that
We have to reduce the dose.
you will not be able to increase the dose of methadone until 5 days. But in case of morphine, you can increase the dose every day. But in case of methadone, you have to wait for at least 5 to 7 days. So this is one thing which you have to keep in your mind regarding methadone. Otherwise, there will be a complication. Yeah, yeah. Dr. Vinodha says there will not be acute pain relief. Yeah, there will not be sustained pain relief for 5 days. That's what we have to understand. I told you that 2 to 4 hours methadone will be available in the blood, during which time there will be some pain relief. But for a sustained blood level, it will take about 5 to 7 days. And even in elderly and patients with hepatic failure, it may take even more, like up to 2 weeks. So it is better to wait for 2 weeks in elderly more than 65 years and patients with liver failure. Next, 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 next. Okay, so we told that morphine is metabolized in the liver. So there are, you can see, there are many cytochrome enzymes involved in the metabolism of methadone. And the major cytochrome P enzymes are 2B6, 2D6, and 2C19. And so because there are many medications which are metabolized in the liver, so there will be drug interaction. This is what another thing which you have to keep it in your mind. So when you start patient on methadone, look for other medications which are going to interact with methadone. Next. And we told that because of the action on human either a go gene, there is a possibility of toxoidopoints, and there are many risk factors for toxoidopoints. So these all are the risk factors for toxoidopoints, and we can see most of this can be a problem with the patient that we see. Electrolyte abnormalities, that's very common problem in our patients. Age more than 68, and we know that cancer will be more when patients become aged. Female gender, structural heart disease, genetic predispositions, and there are many drugs which can produce the or increase the QT interval. So be careful while you prescribe methadone and other medications. Patients with the corrected QT interval more than 450 seconds. And when the methadone dose increases, it is also another risk factor for toxoidopoints. So there are many risk factors which we have to consider while you prescribe methadone. Next. So how do you monitor the patients? So before starting a patient on methadone, we need to have a few investigations. Most importantly, one ECG and some electrolytes like calcium, potassium, and magnesium. So these are the two investigations which we need before starting methadone. But you also need to understand that we need not do all these investigations for each and every patient. Suppose the patient is terminal, I am not going to do ECG and electrolytes. There, my goal of treatment is comfort care. In such patients, I will not do any investigation. But if a patient is on curative treatment or palliative oncological intervention, then we need to monitor the patient with ECG and electrolytes. So understand that your what investigation has to be done is depending on the goals of care. And how do you follow up the patient? An ECG need to be done after 2 to 4 weeks. First, at initiation of methadone, then after 2 to 4 weeks, when the patient dose reaches 30 to 40 milligram, and then you can increase the dose. And when the patient dose reaches 100 milligram, another ECG can be done. And when you add other medication, which can also increase the QT interval, then you may do an ECG. But as I told you earlier, all these need to be depending on the goals of care. Next. So I already told you that methadone can increase the QT interval and it can produce torsade points. But there is a catch here. And many of the physicians are scared methadone because of this problem. And the evidence of QT interval prolongation and torsade points mainly comes from patients who are on substitution therapy. And the patients who are on substitution therapy requires hundreds of milligrams of methadone. So when the dose of methadone increases, the chance of prolonging QT interval is also more. So most of the studies have been conducted on patients with substitution therapy. But here is a study which was conducted by a palliative care group at MD Anderson Cancer Center. That actually monitored ECG in about 100 patients at baseline, 2 weeks, 4 weeks, and 8 weeks intervals. But and the dose of methadone used was less than 40 milligram, and they found out that there were no events of torsade points or ventricular fibrillation. So what we have to understand is at lower doses, methadone could be used safely. This is what we have to understand. Next. So I told you that there are many drugs which can interact with the methadone. And these are a few drugs which you need to be careful. There are cytochrome P inhibitors as well as cytochrome P inducers. So cytochrome P inhibitors, the acronym is GPACMAN. Grapefruit. What is grapefruit? What is grapefruit? It is not same as grape. It is something, I don't think it is available in India. It is like a lemon, citrus fruit. So grapefruit is not the same as, same as grape. Protease inhibitors are medication which are used as antiretroviral therapy. And azole antifungals like fluconazole, ketoconazole, meconazole, etc. Then some of the cytotoxics like cyclosporin and the H2 blockers like cimetidine, macrolide antibiotics, azithromycin, clarithromycin, erythromycin, amiodarone, and some calcium channel blockers. So these are medications which are actually, when you introduce or when you give this medication along with methadone, there is a chance of increased methadone dose in the blood. So it is advised to decrease the dose of methadone by 30% when you start this medication along with methadone. And you can see on the right hand side, there are cytochrome P inducers, and the acronym is PSPOX. phenytoin, smoking, phenobarbital, oxcarbazepine, rifampicin, rifabutin, carbamazepine, St. John's wort. And when you give cytochrome P inducers, there will be a decreased blood level in methadone. So it is not going to cause toxicities, but sometimes it can reduce the pain relief. So all that you need to do is watch the patient for withdrawal symptoms or reduced pain. So from this slide, which I think you have to understand is the importance of drug interaction with methadone. Next. Next. So which are the patients whom we can start on methadone? Actually, methadone is an opioid, so it should not come in as an adjunct, isn't it? So adjuncts are medications whose primary indication is not pain relief, but is helpful in some painful condition. That's the definition of adjunct analgesics. But here in literature, it is considered as an adjunct when it is used in smaller doses, like 1 milligram or 2.5 milligram at night. So when suppose a patient who is on morphine 10 milligram every 4 hourly, he says, I have good pain relief during morning hours, but I have to wake up at night because of pain. So in such patients, if you add a small dose of methadone like 2.5 milligram, that patient will get good pain relief. And in such situation, it is called as adjunct in literature. Okay, so don't get confused. And if you have a patient whom we have started on many medications and given opioids and there is no pain relief. So pain refractory to other opioids, methadone is a choice. And methadone is excreted mainly through bowel. So you can, this can be a choice in patients with renal failure. And as I told you earlier, the duration of action of methadone is 8 to 12 hours. So if the patient requires a long-acting opioid, methadone would be a safe choice. And if the patient is on a high opioid, high dose of opioids, and the patient has tolerance, then many patients can have, or some of the patients can have opioid-induced neurotoxicities like delirium, myoclonus, extreme drowsiness, etc. So in such situation, also methadone is a good candidate. And allergy to other opioids. So these are the few indications where you can start the patient on methadone. Next. So there are some contraindications also, or patients who are inappropriate to start methadone. If you get a history that in the family there is a sudden unexplained sudden death in the family, because we know that QT syndrome can run in family. So in such patients, we will not start on methadone. And corrected QT interval, if more than 500 milliseconds, then that's a contraindication. And most importantly, we may see many patients who have poor cognitive function and there is no reliable caregiver. So don't start patient on methadone. Methadone is not like morphine. So without a reliable caregiver, it will not be wise to start a patient on methadone. And if you are unable to follow up the patient, don't start, because you will not be able to get the details from the patient, what dose he is taking, and is there any signs and symptoms indicating the toxicity. So don't start patient if we are unable to follow up the patient. And it is also not used when the patient has acute pain. Next. So this is the formulation available in India. tab methadone and syrup methadone. Tab methadone is 5 milligram. The trade name is R-meth. Both are R-meth. This is produced by only one pharmaceutical industry in India, Rusan. And a syrup is also 5 milligram per ml. The bottle contains total 150 ml. And as of now, in the market, tablet is not available, only syrup is available. But we expect that in a few months, the tablet would also be available. Next. So we will move on to methadone conversion. How will we convert from one opioid to methadone? So it is not like tramadol or codeine or fentanyl. So we can say that tramadol is 1 by 10 less potent as morphine, and you can convert with that ratio in any doses of with any doses of tramadol. But methadone is not like that. We'll go into that. Next one. So this is the methadone conversion chart. So for converting a patient onto methadone, first you have to calculate what is the oral morphine equivalent that patient is taking. So whatever be the patient is taking, suppose the patient is taking fentanyl, you have to convert the fentanyl into oral morphine equivalent. So look here, if the patient is taking less than 60 milligram of oral morphine equivalent per day, you can start the patient on 2 milligram to 7.5 milligram per day, 2 to 7.5 milligram per day. Okay. And if the patient is taking 60 to 199 milligram oral morphine equivalent per day, and if patient is less than 65 years old, the conversion ratio is 10:1. More than 200 milligram oral morphine equivalent per day, or if the patient is more than 65 years old, conversion ratio is 20:1. So you can see at a different dose of methadone, the conversion ratio is different. It is not a linear one like any other opioid. And another important thing is, whatever be the situation, never start the patient more than 30 to 40 milligram per day. That's the maximum starting dose. I have shown you a few examples from the literature. One patient was taking 15,000 of 12,000 of oral morphine equivalent, and another patient was taking 1,000 milligram of oral morphine equivalent. But both patient was started on 10 milligram TID, and they got very good pain relief with 10 milligram TID. So don't start more than 30 milligram per day. Next. So this is how you can titrate. If the patient is taking less than 30 milligram per day, total dose of methadone, if the total dose of methadone is less than 30 milligram per day, you can increase 5 milligram every week. And if the patient is taking more than 30 milligram per day, you can increase 10 milligram per week. So once you increase 10 milligram, wait for another week to increase the dose. And as I told you earlier, if the patient is having normal liver function, we can increase the dose after 5 to 7 days. But if the patient has hepatic impairment, or if the patient is elderly, then it would be wise to wait for up to 2 weeks. So this is the time when the methadone level would be stabilized in the blood. Next. Yeah, next. Okay, so this is a 37-year-old man. We are actually moving on to conversion. These are real patient stories. 37-year-old man with who is diagnosed to have carcinoma of the buccal mucosa in 2018. But during that time, immediately after this diagnosis, he was also diagnosed with second primary papillary carcinoma of the thyroid, for which he underwent surgery and radiation. Next. And in 2019, he has an level 2 nodal recurrence for which he underwent surgery. Next. And after that, his main problem was severe pain, which was starting inside the left ear, going back to the head, and then to submental region. He described it as severe pain, 10 by 10, pricking. The treating team did extra oral mandibular nerve block thrice, but he did not had any pain relief. Next. So they tried him on injection morphine, but it produced toxicities. And then they started him on oral morphine. So this is what they have started him on 10, 15, 10, 30 and 10 milligram SIS. And patient had toxicities with this dose. Next. And they also tried on various adjuvants, but there were no pain relief. And this was the medication the patient was on when he came to us. Morphine, pantoprazole, ciprofloxacin, acetylopram, serratiopeptidase, diclofenac patch, paracetamol 650 milligram. Yeah, next. Do we need to start this patient on methadone? Anybody? Or is this patient a suitable candidate to start methadone?
Anyone would like to respond to that question?
Yes, due to her morphine toxicity. Yes, what is why this patient is a suitable candidate? What are the indications to start methadone in this patient? Opioid toxicity, that's right. Anything else? Sorry, Deepak, we can't hear you. Your voice is breaking. Neuropathic pain, yes, yes. Opioid tolerance, that we don't know because this patient is on very small dose of opioid. So we can't say it is opioid tolerance, but this patient has opioid toxicity. That's right. The patient has neuropathic pain. That's also right. And this patient was already tried on adjuvant analgesics and interventional pain analgesia for neuropathic pain. Even with that, he didn't have good pain relief. So he's a candidate to start on methadone. Next. So you decided to start the patient on methadone, but before actually starting, what are the points that you have to be careful? Anybody? First, you have to ask the patient. Yeah, liver function. Very good. Anybody? ECG, yes. Yeah, ECG, yeah, electrolytes. Yes, ECG and electrolytes. So we also need to ask the patient, is there a history of sudden unexplained death in the family? Because I told you congenital QT syndrome can run in families. And the second thing is there a reliable caregiver to administer medication? So these are two things which you have to ask. Yes, Dr. Sivakumar, tricyclic antidepressants. No, as of now, the patient is taking only this. Morphine, pantoprazole, ciprofloxacin, acetylopram, serratiopeptidase, diclofenac, paracetamol. So the two questions we have asked. Is there a history of sudden unexplained death? Is there a reliable caregiver? There is no history of sudden unexplained death. There is a reliable caregiver. Then you did an ECG and electrolytes also, calcium, potassium, magnesium. So both are normal. Corrected QT interval is also within normal limits. It should be less than 450 milliseconds. Are you worried about anything else in this patient?
The patient is taking escitalopram.
Yeah, escitalopram is something which can interact with methadone. So yeah, a drug interaction. Escitalopram, ciprofloxacin, pantoprazole, all these three can interact with methadone. So you have to find out some solution for this. Okay, next. Next. Yeah, so you have to change ciprofloxacin to some other safer antibiotics. Fluoroquinolones has interaction with methadone. So maybe a penicillin group of antibiotics is better. Pantoprazole can be changed to ranitidine or famotidine. And in this patient, actually, escitalopram was not indicated because he was not in clinical depression. The treating team started him on escitalopram because of poor pain relief, but there were no indication there were no clinical depression. So we stopped escitalopram. Next. Continued on paracetamol. He was getting SOS. We made it 6 hourly. Next. So how can we calculate methadone dose? So as I told you, you have to calculate the methadone equivalent daily dose or oral morphine equivalent. Both are same. Oral morphine equivalent or methadone daily dose. So this patient was taking total of 65 milligram. And this patient's age is 39 years. So the conversion ratio or the morphine equivalent daily dose or oral morphine is equivalent is between 60 to 199. So the conversion factor is 10:1. So total dose of methadone would be 65 divided by 10, which is 6.5 milligram. So syrup methadone 2.5 milligram BD, that is 5 milligram. Or if it is tablet, you can start him on only tablet is available. You can start on 2.5 milligram BD, or if syrup is available, it could be 3 milligram BD. But you also know that it will take about 5 to 7 days to get a good pain relief. So you will also continue with morphine on an SOS basis. So look at here, you are writing tab morphine 10 milligram Q4H SOS. It is not Q4H and SOS. It is only Q4H SOS. Okay, that means when you start patient on methadone, suppose you gave 2.5 milligram, and at that time you will ask the patient, do you have pain? Patient says, yes, I have pain. You will give morphine also 10 milligram. And at 10 o'clock, you will again ask the patient, do you have pain? Patient says, no, I don't have pain now. You will not give morphine. But at 2 p.m., patient says, I have pain. You will give morphine 10 milligram. So that's what 10 milligram Q4HS means. Will it be the same if give syrup methadone 6? So I told you that the duration of action of methadone is 8 to 12 hours. So it would be better to give twice daily at least. So that's why it is given like that, BD or TID. Next. So this patient was started on methadone 2.5 milligram BD and morphine 10 milligram as Q4H SOS, and he had better pain relief. Next. So you can see how we increase the dose of methadone, and this was one of our early patients. So at that time we were not confident enough to titrate the morphine. So we had fear in our mind. Will it be more and will it cause any problem? So this is the problem that you can also expect if you are new to this medication. That's why you can see the very small increase in the dosage. But anyway, this patient had very good pain relief. and he lived, I think, 3 months at his home, doing his activities of daily life. And when he came here, he was in very severe distress, and actually family was totally distressed, and you saw the posture of the patient. So, but after starting on methadone, he had very good pain relief. Next, next, next. So this is another story of a 39-year-old woman with the carcinoma of the pancreas, stage 4, with liver, lung, and splenic metastasis, who underwent 5 cycles of chemotherapy. But then oncologist stopped the chemotherapy because the disease was progressive, and she was receiving palliative care. Next. So you can see this is the pain pattern for the last 2 months. Her pain is 10 by 10, and with morphine, tramadol, and paracetamol, it is coming down to 7 by 10. Next. And also myoclonus were present. Next. This was the medication the patient was receiving. Yeah, stop. So, what do you think? Is this patient a candidate for methadone? Yes. What is no? Dr. Abhishek says no. Yes and no. So can both participants come up with their comments why it is yes and no? If it is yes, why it is yes? Yes. Morphine toxicity. Yes, that's one indication. What is the from the distribution of the pain, how it looks like, and from the description? What type of pain it is? Yeah, neuropathic pain. So both those are indication to start the patient on methadone. Yes. Next. Okay. Next. So what are the investigations you are going to do in this patient? What is the goal of care in this patient? It is only comfort care because patient is with there is no investigation needed actually, because the goal of care is comfort care, because the patient has stopped chemotherapy and in probably in the last few weeks of her life. So actually we need not do any investigation as such in this patient. Next. So what is the conversion factor in this patient? Anybody? What is the conversion factor? I will give you 1 minute. 80 by 10. Vinodha, I think we need some modification. Not 80 by 10. What is the oral morphine equivalent this patient is receiving?
One 20 milligram.
Yeah, let's see. Let's see. Okay, next. Next. Yeah, next. So this patient is getting 20 milligram morphine 6 hourly. So total morphine dose would be 80 milligram. But in addition, she is also receiving tramadol. So we have to also calculate what is the oral morphine equivalent of tramadol. So 100 milligram TID, total 300 milligram. We know that tramadol is 1 by 10 less potent as morphine. So we have to divide 300 divided by 10. So that will come to 30 milligram. So this patient next. Patient is receiving total oral morphine equivalent of 110 milligram. So what is the conversion ratio? Between 60 and 199. And patient is 39 years old. So the conversion ratio would be 10:1. Next. Yeah, next. So methadone dose would be 110 divided by 10, 11 milligram. Next. So you can start with tablet 5 milligram BD. Next. So we started this patient with methadone and morphine as on an SOS basis. We continued gabapentin, amitriptyline, and bisoprolol. We know amitriptyline can interact with methadone, but it's very small dose, 25 milligram. So we didn't stop that. We continued that. And this patient had excellent pain relief. Actually, this patient was confined to bed and she was unable to look after her children. And she was very much worried about that. But after starting methadone, she was able to go out. She was very independent for the last 2 months of her life. And next. So this is another patient, 40-year-old man with advanced malignancy of the lung, pain on both lower limbs, T12 compression fracture due to metastasis, and he is complaining of burning pain, which is continuous in nature, and patient is already on 40 milligram Q4H and SOS. Next. Next. Sorry, come back. Back. So is this patient a candidate or is this patient a good candidate for starting methadone? With 40 milligram morphine Q4H,
Yes,
he
sir.
doesn't have proper pain relief. Okay, so why he is a good candidate for methadone?
Morphine toxicity,
Yeah.
neuropathic pain.
Okay. We have not. There is no morphine toxicity from this case history, but neuropathic pain which doesn't have proper pain relief with oral morphine. So what is the oral morphine equivalent that this patient is taking? What is the oral morphine equivalent he is taking? 40 year old.
240.
Yeah. Next slide. Next. Yeah. This patient is taking 40 milligram every 4 hourly. So it is total 240 milligram. And next. So what is the conversion factor? Patient
20
age is 40,
20
but his morphine dosage is between 200 and 200 and above. So the conversion factor is 20:1. Next. It is 20:1. So we have to divide 240 divided by 20. That will come to 12 milligram. So how do you start 12 milligram methadone on a patient? What would be the dosage you are going to use? 3
6
milligram
milligram
TID.
BD.
Yeah, 6 milligram BD or 3 milligram TID. Both are okay. Next. Or if you have only tablet, maybe 5 milligram BD or 5, 2.5, 5. That will be 12.5. All are okay. Okay. Next. And you have to continue with tab morphine 40 milligram Q4H on an SOS basis. And you also understand that methadone will cause constipation. So we have to give stimulant laxative along with methadone. So you will continue the previous laxative, bisoprolol, which were used with morphine. Okay, next. So if you want to know more about interaction with methadone, here is the link you can go, and there is a list of medication that can prolong QT interval in this crediblemeds.org. Next. So before ending the session, a few points which I think important is even though there are some problem with you can unshare the screen. Even though there are some side effects for methadone, the benefit will outweigh the risk associated with methadone in patients who are having severe pain. So if you select patients wisely, then methadone is a good choice for those patients. And you know that with morphine or phenyl, at least some of the patients will not have proper pain relief. In such patients, methadone can be used and will be a good alternative. And in patients with renal failure also. But the important things you have to keep in mind are, one, you don't increase the dose of methadone till 5 to 7 days at least. Then never start the patient more than 30 milligram per day. Then there are many medications which can interact with methadone, and some medications can also prolong the QT interval. So be careful what are the medication this patient is on, and stop medication which you think is not necessary. I would advise you to keep a simple prescription for patients on methadone. And the conversion ratio, there are many conversion methods available if you look at the literature, but this is the newest one, which is a consensus by hospice and palliative care physicians in 2020, which we also follow. Thank you. If you have any doubts, I will take it now.
Thank you so much, sir. As sir mentioned, we'll take up a few questions if you have any on methadone.
Sir, have you come across this torsades point as a common adverse effect, or it's a very rare thing in your career?
Yeah, thank you. Thank you for that question. I haven't come across any torsade points. And one of the important thing you have to understand is, even though torsade point has been documented very well in the literature, the most of this is coming from patients who are on opioid substitution therapy with methadone. So these patients will be on higher doses of methadone. So when the dose of methadone is higher, there is a chance of producing torsade points. But for our purpose, for pain relief, we need only less than 30 to 40 milligram per day, which is usually very safe, which I have shown you with the study done by the MD Anderson Cancer Center.
Thank you, sir.
Thank you.
There's a question in the chat. I hope you are able to see it. Any psychotropic effects similar to NMDA antagonist?
No, it's not like, even though it has an action on NMDA, when the dose becomes more, morphine, when it is given in higher doses, it can produce some delirium, hallucination, etc. That can also be there if the dose of methadone is higher. Otherwise, it is not like ketamine.
So there is another question. Is it safe to start in a home care setting?
We use methadone for our home care patients, and it is safe to start. It will be better if you start them on, maybe if the patient requires less than 15 milligram, maybe in home care it is better. But if you need higher doses, then it would be better to admit. There is no such rule, but when we are starting patient on methadone, because this is a new medication to many of us, so I think it would be better if higher doses are used to get admitted the patient.
So can we combine tramadol with methadone?
Okay, so that's a tricky question, because you might be thinking of serotonin syndrome, because tramadol also increases the reuptake of noradrenaline and serotonin. But I think if you come across such a situation, tramadol can be given on an SOS basis. But keep in your mind, can there be any serotonin syndrome?
Any other questions? I mean, even other than methadone, if you want to ask any questions on opioids also, that's fine. I think if there are no other questions,
Do you want to discuss any of the questions from the polls that we did?
yeah, if you have any question, yes, Dr. Bilal. I guess, sir, I think they are asking for the assignment results.
Yeah, no, we did,
Your poll
yeah.
results. Sir.
Can you launch the questions once more, Shreya? So what is the duration of analgesic effect of methadone? Anybody can answer this. Anybody? Yeah, 8 to 12 hours. Next one. Methadone can produce torsade points, especially in higher doses, which can lead to sudden death. That's true. Methadone has the following actions except agonistic action on opioid receptors. So we know that it acts on mu kappa delta opioid or receptors as agonist, and then it is also an NMDA antagonist. It also has a tricyclic action. The odd one out is prostaglandin inhibition. Next one, the risk for torsade points starts at the corrected QT interval of 450 milliseconds and is significant at 500 milliseconds. That's true. So 500 milliseconds is contraindication. Next. Methadone has an NMDA activity that is equal to ketamine. From the literature, I see that the NMDA activity of ketamine and methadone is comparable. So it's true. Methadone is mainly metabolized in liver, which is correct regarding pain relief. Methadone and dextropropoxamine are safe in chronic kidney disease. Methadone and codeine are safe in chronic kidney disease. Methadone and fentanyl. So methadone and fentanyl are safe in chronic kidney disease. That's the right answer. The oral bioavailability of methadone is as follows: 70 to 80, 30 to 40, 20 to 30, 10 to 20. You can say it is 70 to 80. Next. Next poll. Supriya, please launch the next one. Yeah, methadone can be administered through the following routes. So we know that oral, parectal, sublingual, subcutaneous, and intravenous. All the routes. Methadone blocks human either a GOGO related gene in myocardium and can lead to increased QT interval. That's true. The following medication can cause increase in QT interval if co-administered with methadone: azithromycin, ciprofloxacin, acetalopram, haloperidol, none of the above, all of the above. Okay, actually, and this question is not the answer is not very good answer, because all the medication can increase the QT interval. So it is none of the above can be the answer. So all the medication can increase the QT interval. So we have to reframe this question. Methadone blood level will be stabilized after 5 to 14 days. That's the correct. because in the normal circumstances, it will take 5 to 7 days. But in patients with hepatic failure and patients who are elderly, it will take about 2 weeks. So 5 to 14 days. Medications that can decrease methadone levels in blood are dexamethasone. All the others can increase the blood levels. Methadone is easy to use just like morphine. No, it's false, because we know there are many problems. Following are the indication to use methadone, except opioid toxicities as an adjunct, complicated neuropathic pain, safe analgesic in renal failure, allergic to other opioids, opioid-induced hyperalgesia tolerance. Following are the indication to use methadone, except. So, well-controlled pain is the most appropriate answer. But if somebody says all these are indication, I would also agree. Because even in well-controlled pain, if you want to switch over the patient to from suppose patient is on 20 milligram of morphine 6 hourly, patient says I don't want to take it every 4 hourly, please give me some medication which can be taken less frequently, then I may convert him to oral methadone to an equivalent dose. So that can also be. Thank you.
Thank you, sir. Are there any other questions from the poll questions? I hope everything is clear. If there are no other questions, maybe we can wind up today's session and have a few minutes of feedback from you all, because today will be the last session for your batch. Thank you, Dr. Sunil, for being with us and to deliver a wonderful session on methadone. Thank you so much. But if there are any other questions, we'll definitely divert to you through email or message. Thank you so much, sir. We would like to hear if there are any suggestions from your side to, in terms of this delivery of this course, anything to improve, anything that we should look into, because we run this course every other month. So it's your feedback is really important for us.
Ma'am, can we have extension of the course?
Sorry, what did you mean, Dr. Shweta?
Ma'am, will we have more courses like this, advanced ones?
Yeah, yes, we'll be having a refresher course in palliative medicine, which will be tentatively in the month of April. Whichever course we are starting, we'll be circulating that in the WhatsApp group. So there will be refresher course, and right now, if there are any pulmonologists in the group, we are starting a batch specifically for pulmonology palliative care for chest physicians, which will be starting in the month of March. So I'll forward all the details in your groups. But there are
Can
refresher courses.
anesthetists join this, because we also work as pulmonologists?
If you are seeing patients, I mean respiratory patients, I think yeah, you can.
Yes, ma'am. Majority of the patients in the ICU are respiratory,
Yes,
and especially in the COVID and post-COVID era.
Sure. We'll send the brochure and the details of the course in the batch WhatsApp group. So if you find it relevant according to your setting, please just write to us. And we'll be starting the refresher course soon. We keep on giving you, as you said, advanced courses or I mean specialty specific courses regularly. But whatever information about courses, we'll send emails or messages.
And ma'am, for a hands-on work experience also, can
Yes.
there be a short period, like for 1 week or 2 weeks?
Yes, so today we'll be sharing a document with you all in the group, where we have we have divided, we have given the details of centers almost in all the states with the contact person and the contact number and email IDs. So either you can contact them directly or you can choose one center and just send us email that I would like to go to this center for a week for observation. So we'll connect you with the person over there and then you can go for hands-on training. If you are planning to visit our institution in Kerala, again, please write to us because of the COVID, the Kerala situation due to the pandemic, we might have restrictions in number. So if you can plan in advance and let us know, we can schedule the hands-on training.
So there is one comment from Dr. Jibin. He says offline classes is much better than online.
Yes, we totally agree. If we had a choice, then we would have, like we had the major training program happening in the TIPS was on-site training program. We have a 6 weeks course for doctors, which is certificate course in pain and palliative medicine, which we had to withhold in last 2 years. We are restarting that probably in the month of March, but we didn't have choice to start that last 2 years.
Thank you, Dr. Vignesh, for your comments. And Dr. Bilal asked about any handbooks for common drugs in palliative care. So there is a book called Palliative Care Formulary, which is available, but it is costly, I think more than 10,000 rupees. But it is a very useful book for understanding the common medications and indications in palliative care. It is written by Robert Oikos and his colleagues.
And for Dr. Shweta's question, we are starting with the mentor-mentee program, where if you want to have continuous mentoring, we are offering very small group, just patient. There is no theory session. You can have your patients to be discussed in a very small group, like 5 people and a mentor. So there will be an expert and 5 learners. So that we are starting soon. So all these courses we'll be putting in the WhatsApp group. So you can just write to us or register through that link which has been given.
Okay, ma'am. Thank you.
Dr. Sevi, you are from Malaysia, isn't it? Yeah.
Yes.
So do you have any feedback for us to improve on or anything?
I think quite good. It's eye-opening, at least sharing, see how other people do palliative care in other countries.
Okay, thank you.
If you want to tell something in terms of improving what we are having right now, just write to us or you can share now. And if you come across any, if you want to ask some doubts in terms of medication or anything with respect to palliative care, you can just put in a message in the WhatsApp group, or we have telehealth. Like some of us will be responding to the questions.
So we run a telehealth line, which is available from 9:30 to 4:30 p.m. And if you have any doubts regarding management of the patient, you can call on that so that we can help you.
Yes, Dr. Sunil, we understand the timing. We have, I think we have experienced many timings. So we used to have sessions at 3 o'clock. Then we found that doctors will be treating patients and attending the sessions simultaneously. And they could not pay much attention. That's so majority felt that they'll be more engaged if the sessions are at 5 o'clock. At least they are going back home. Later on at night, that might be difficult for us to coordinate from the hub. So yeah, we understand that we never get good timings for everyone. Either it will be okay for majority, and some people would definitely find it difficult. Yeah.
So Sripriya, can you post the numbers of regional coordinators in the?
Yes,
Yes, sir, will be done.
And the list of centers also we'll put in the document we'll put in there. So you can just see whether you want to go there for hands-on training a week or 10 days or 2 weeks, whichever is that you can choose. If there are no other comments, I think we can say bye-bye. I think there'll be one more short assignment which will be sent soon. So kindly finish that so that we can proceed with the certification. Over to you, Shripriya.
Thank you, Sridevi ma'am. Thank you, Sunil sir, for joining us for that wonderful session. I believe this also was very informative for everyone, just like the other sessions. So that brings us to the end of online sessions for this particular cohort. Rest assured, as Sridevi ma'am said, we are there to support you for medical or non-clinical matters. The concerned persons will definitely get back to you when you are communicating through mail or WhatsApp or SMS. And we do hope that whatever things, whatever knowledge you had taken from here, may it help you to practice better and bring painless surroundings and dignified life, enrich the quality of life to people around you. So with that note, this is Sripriya along with Dr. Sridevi signing off from the Tips Eco Hub. Stay connected and stay safe, be happy. Take care, everyone. Bye-bye.